This broadcast is sponsored by Radiometer America. Radiometer's mission is to help caregivers make diagnostic decisions that save lives. In fact, every day, 500,000 blood gas samples are tested around the world using radiometer equipment. That's 7 samples per second. That should tell you they know a thing or two about testing. I work part-time at JPS Health Network, the county hospital in Fort Worth, Texas, and we use radiometer blood gas analyzers at my hospital. I like them, and I'll tell you, Radiometer did not pay me to tell you that. Now, if you would like to be contacted by Radiometer about their products, please send us an email and we will be happy to forward your information along. Just send it to mail, M-A-I-L, at respiratoryassociates.com.
Well, hello out there, my friends in respiratory care. I'm Dr. Arthur Jones, and I'm speaking to you from Bensalem, Pennsylvania, which is a little community outside of Philadelphia. Anyhow, welcome. The topic for today is non-invasive ventilation, which is something that you do all the time if you work with patients who require ventilation, regardless of the reason why. Anyhow, let's go to the learning objectives. When you complete this lesson, you will be able to explain the rationale for non-invasive ventilation, describe the effects, indications, advantages, disadvantages, and complications associated with negative pressure ventilation, describe the operation of specific negative pressure ventilators, describe the modes, effects, complications, indications, and contraindications associated with non-invasive positive pressure ventilation, that's NPPV. Describe the evidence basis for NPPV for selected conditions. Evidence. Compare the interfaces used in NPPV with respect to their indications, advantages, and limitations. Describe the issues pertaining to types of NPPV circuits and humidification systems. Compare the ventilator types and modes applied to NPPV with respect to their advantages and disadvantages. Describe techniques for ventilator control adjustment for NPPV. Finally, discuss the clinical issues pertaining to NPPV, include aerosol delivery, heliox, clinical sites, and end-of-life care. Ooh, a lot of objections there. Okay, we're going to begin with negative pressure ventilation. I'm sure that many of you have never experienced negative pressure ventilation. I certainly have. Look at some definitions here. Non-invasive ventilation, the topic for today, is simply mechanical ventilation without a tracheal tube. There is non-invasive positive pressure ventilation. Yes, indeed, we will be taking a break, and I'll let you know when that's going to happen. Then NPV, ventilation without a tracheal tube and with positive airway pressure. Negative pressure ventilation is ventilation with negative pressure applied to the thorax. So what is the rationale for non-invasive ventilations? The idea is to be able to ventilate patients while avoiding the complications associated with tracheal tubes, such as ventilator-associated pneumonia, airway trauma, and psychological trauma due to the patient's inability to speak and the patient's being restrained. Look at the physiologic effects of negative pressure ventilation. As I said earlier, negative pressure ventilation is achieved by applying negative pressure to the thorax as opposed to positive pressure in the airways. And you see in this cartoon, you see where the pressure is pulling outward on the chest to expand the lungs. And also, since the heart is in there, you can imagine that the heart is being expanded also. Important point. The effects of negative pressure ventilation, of course, decreased work of breathing. The idea is for any ventilator, positive or negative, to assume some or all of the work of breathing on the part of the patient. Also, we get increased distribution of ventilation, and the subambient pressure inflates the lungs. It can be intermittently with passive deflation. We can also, as opposed to ventilation or as opposed to intermittent ventilation, we can apply continuous negative expiratory pressure, which is analogous to PEEP, to maintain the patient's functional residual capacity. Another effect of the negative pressure ventilation, we get increased pulmonary blood flow. The ventilator is sucking blood into the pulmonary capillaries. We also get increased ventricular filling. Therefore, specifically with the Curos type of negative pressure ventilator, we get increased cardiac output. Important point, folks. Remember that. Okay, the indications for negative pressure ventilation. Some patients cannot tolerate a mask. If the patient is unable to fit or tolerate the mask, then negative pressure ventilation is an alternative. It is also indicated for neuromuscular disease, neurological trauma. In these neuromuscular disease, the patient is just losing their ability to ventilate through muscles or neurologically. Therefore, the lungs are normal, are relatively normal, and therefore the patient just needs the ventilation. It's also indicated for patients who cannot tolerate the increased mean airway pressure. It's, for example, positive end expiratory pressure. Can also be used for patients with COPD in a chronic state and also during acute exacerbations. Other indications for negative pressure ventilation, post-congenital heart surgery, specifically in children, in babies. It is very easy, regardless of how skilled the surgeons are. It's very easy for surgeons to nick the phrenic nerve. And when that happens, the phrenic nerve will not power the diaphragm. Therefore, the nerve becomes severed and the patient just needs help ventilating. This can happen after tetralogy of Fallot correction, tricuspid atresia correction, where the patient gets a Fontan procedure, and it involves, again, phrenic nerve injury. Can also be used in neonatal respiratory distress and also bronchopulmonary dysplasia, which we see long-term COPD in babies and in children. Other indications include post-emphysematous lung resection, because it's not applying pressure to the lung itself, to the thorax. It's more likely to be useful. Negative pressure ventilation can be used during microlaryngeal surgery because there's no tube needed. Can be indicated for cystic fibrosis, weaning from positive pressure ventilation, flail chest, where we may only need to use continuous negative expiratory pressure. Again, the analog of PEEP. It may be useful. That's where the questions. It may be useful in meconium aspiration. It also may be useful in a patient with a bronchopleural fistula. So the benefits of negative pressure ventilation. First, it avoids tracheotube complications, which I've mentioned before. Yes, indeed. Congenital heart disease. Okay, we'll also avoid, with negative pressure ventilation, there is no mask. So you can avoid the facial trauma from the mask, reduce sedation requirements, and with negative pressure ventilation, there is no ventilator-induced lung injury. That's a big one. Other benefits with negative pressure ventilation, a patient can talk. The patient can cough, which is useful. And finally, the patient can have improved enteral nutrition. The patient may be able to eat. That's not a given. They may be able to. Disadvantages of negative pressure ventilation. First, there is no protection of the airway because there is no tube. Another disadvantage is that some of the equipment is large and not very portable, very difficult to transport. I'm thinking of tanks here, tank ventilators. And believe it or not, I have used tank ventilators in the past, and these were for patients with residual poliomyelitis and also patients with muscular dystrophy. With tanks, we get decreased patient access. When you see a picture of a tank ventilator, you'll understand. Disadvantages also, this form of ventilation, except for maybe one exception, is very cumbersome to apply to some patients, especially tank ventilators and wraps. And if you've ever used a wrap, Pulma wrap, you know it's a nightmare. Okay, other disadvantages. It is difficult to maintain a seal. It is difficult to monitor volumes, although it is doable. And there may be intolerance from the patient that varies with the type of negative pressure ventilator. Complications of negative pressure ventilation. This is with the tank. Peripheral venous pooling. The tank is applying negative pressure to the whole body, with the exception of the head. And that can cause venous blood to pool in the periphery, causing tank shock. We can also get gastrointestinal bleeding due to this increased blood flow in the stomach, in the in the GI tract. Also, the negative pressure to the peripheral airways can cause the upper airways to collapse, dynamic upper airway collapse. We get irritation at the neck seal with the tanks, although this can be minimized by using certain precautions. The final complication with negative pressure ventilation is back pain, especially with the tank. It is contraindicated. Negative pressure ventilation is contraindicated by obstructive sleep apnea. Indeed, it would make it worse because of the dynamic airway collapse. It is contraindicated in patients who are morbidly obese because it simply may not work. Contraindicated by severe kyphoscoliosis and also recent abdominal surgery. Okay, let's take a look at some of the negative pressure ventilators. This is an oldie but goodie. This is the Drinker-Shaw iron lung. You see, there is a mirror for the patient to see at least what's going on behind them. You can see where the patient's head protrudes from the tank and where the patient will be. Just looking at this, you can see why the patient would develop back pain. And this is one that I have used quite a bit. This is the Emerson iron lung. And I'll tell you one thing, the Emerson iron lung will take a licking and keep on ticking. Anything that goes wrong with the Emerson iron lung, you can fix it by going to any hardware store and getting parts that will work for the darn thing. So that's the Emerson, and they are still around, I imagine. Okay, here is a portal lung. And I've never seen one of these, but the portal lung is only a tank type ventilator. And you can see there are different sizes of these. And here's one that is not available in the US. This is the Kappa iron lung, and the Kappa also makes a Huros or DID. This is a microprocessor based. This is a state-of-the-art iron lung. But I've got to tell you this: it was a while since I discovered this ventilator and put it in this lesson. And just yesterday, I trying to find it again on the net and could not find it. And it's difficult because so many, when you go searching for anything now on the internet, vendors always come first. So getting good information is getting more and more difficult. Okay, here's one that is in use today, and this is an excellent piece of equipment. This one is the HYEC RTX, and there are different versions of the HYEC. But you see, this is a Kuros ventilator. A Kuros, the word Kuros casually comes from, in the old days, in ancient times, knights had a Kuros they wore across their chest to protect them from injury. And this is another Kuros that fits on the chest, but to allow the patient to ventilate. And here is the biggest pain in the ass that you can ever imagine if you ever try to use it. I have a couple of times. This is the Pulmowrap body wrap. You see, there is a Kuros and a vinyl or a plastic wrap covers the Kuros, and a something like a vacuum, very much like a vacuum cleaner, is attached to it, and so it ventilates. It applies negative pressure ventilation. Expiration is passive. The reason I say it is such a pain in the neck, and I didn't say neck, I'm sorry, is putting this thing on is a job. Maintaining a seal is even more of a job. So I hope you never have to use this. And this is a vintage Kuros ventilator. Oldie but no goodie. Okay, let's talk some more about the HYEC RTX Kuros ventilator. This applies biphasic Kuros ventilation with both inspiratory and expiratory pressure. This one is the easiest one to apply. It just attaches to the chest. The modes include high frequency chest oscillation, and there is a secretions mode which supplies oscillation as well as a cough. And also, we can apply continuous negative expiratory pressure. Let's see a video in the high. I have no financial interest in this ventilator, but I love it.
The history of supportive breathing by mechanical means dates back to the beginning of the 20th century. In the earliest successful ventilators, lung inflation was a result of negative pressure applied to the body. A version of this type of therapy still exists in the form of biphasic Kuros ventilation, or BCV. The negative pressure against the chest and abdomen can be used continuously or in cycle with a positive phase to create improvements in gas exchange in many elements of cardiopulmonary function. In this much refined version of negative pressure ventilation only available with the Hayek RTX ventilator, a chest shell or Kuros is placed over the patient's chest and abdomen and the pressure in the Kuros controlled. BCV can serve as non-invasive ventilation, a lung recruitment tool, and a means of airway clearance and cough support. Many peer-reviewed medical publications support BCV use. Our focus today is pediatric. Many papers have been published related to BCV use in pediatric respiratory care. We would like to share some brief excerpts from 3 papers. In the first 2, efficacy of BCV in the pediatric ICU is demonstrated with mixed respiratory failure patients. The other paper we will look at sheds light on the potential of BCV for patients with chronic care and support needs of spinal muscle atrophy, or SMA, and other forms of respiratory-related neuromuscular compromise. The first pair of papers published in Respiratory Care Journal, the first in December of 17, negative pressure ventilation in pediatric acute respiratory failure, and the other found in the January of 2020 issue of the same journal, predictors of negative pressure ventilation response in pediatric acute respiratory failure. These 2 papers cover the results of the use of BCV by a group associated with Buffalo University and Oishai Children's Hospital as their primary form of non-invasive ventilation on 351 patients between the 2 papers. Their findings included the following from the 2017 paper.
The majority were NPV responders, defined as not needing escalation to any form of positive pressure ventilation. Complications from NPV were rare. The annual percentage of pediatric ICU admissions requiring intubation declined by 28% in the 3 years after NPV introduction, compared with the 3 years prior. Negative pressure ventilation, applied by an iron lung, was the first mode of mechanical ventilation created to support respiratory failure due to poliovirus. It fell out of favor because of its cumbersome nature and its detrimental hemodynamic effects on venous return from the abdomen. Mechanical ventilation delivering a positive pressure via the airway circumvented these issues and became the standard of care. Over time, as the morbidities associated with invasive positive pressure ventilation were discovered, negative pressure technology was re-explored. In general, NPV was started after subjects had ongoing distress, hypoxia, or hypercapnia, despite maximal flows on high-flow nasal cannula. NPV is a non-invasive respiratory support for children with acute respiratory failure from varying etiologies that has few complications and a 70% response rate in a general pediatric population.
From the 2020 paper.
Majority of subjects
Hey, all right, can we move on from this video?
Go ahead, yeah.
All right.
We're sorry about that, folks. That is a glitch in the YouTube platform. We can continue. Anyhow, you see what I mean? Negative pressure ventilation is good stuff when you can do it. Okay, the modes, other modes for the Hayek RTX, high frequency chest oscillation, the secretions mode, continuous negative airway pressure, expiratory pressure. It does have a control mode. It can be triggered by the patient, and it can be synchronized with the patient. Specifications of the Hayek. The rate 6 to 1200 cycles per minute. Obviously, the 1200 is the high frequency. IDE ratios can be varied from 1 to 6 to 6 to 1. The maximum inspiratory pressure is 50. The maximum expiratory pressure also is 50 centimeters. The unit, the weight of the power unit, 9 kilos. There you go, 20 pounds. There are 4 adult-sized cuirasses, 7 pediatric-sized cuirasses. So it should be quite doable to find the correct size for just about any patient. Okay, the settings on these ventilators. The peak inspiratory pressure adjusts the patient's tidal volume. The peak expiratory pressure provides active exhalation and provides assistance with the cough. The continuous negative expiratory pressure helps to maintain the function patient's FRC and also balances any intrinsic PEEP to allow patient triggering. The settings. These are the settings we use: the rate, the respiratory rate, the IE ratio, the trigger sensitivity. The trigger is sensed at the patient's nares, or in the Hayek, it is sensed in the cuirass. To adjust the FiO2, we must use either a mask or a nasal cannula. The monitoring we need to do with these patients, of course, blood gases, baseline and PRN arterial sampling, continuous pulse oximetry, end-tidal CO2 monitoring is a good idea, and also the patient's tidal volumes. We can measure the tidal volume using a spirometer or respirometer attached to a mask applied to the patient. Another possibility is respiratory inductive plethysmography. So where can we do negative pressure ventilation? Obviously, we can do it in intensive care units. Again, I need to point out that the tank requires a lot of space. It is and although a tank can be moved, with the Emerson, you can even ventilate the patient without power by pulling on the diaphragm at the bottom, manually pulling and pushing on the diaphragm at the bottom of the ventilator. Can also be used in intermediate care sites, long-term care facilities, and in homes. When I was in Houston, we had several patients who were in iron lungs at home. One of them even the guy even made his own, and it was a piece of work. I wish I'd taken a picture of it. Patient transport with these ventilators, easier said than done with the big ones. We may need to use, when the patient is being moved, they may require portable positive pressure ventilation. An iron lung, as I just mentioned before, can be manually operated. Done it. There also, with the Hayek, we can have battery. The guy, he was a fascinating guy. He was a plumber, oddly enough, but he welded his own ventilator together. He even put a light inside it. It's beautiful. Okay, so the Hayek MRTX can use battery power. Let's summarize and review for this portion of the show. The rationale for non-invasive ventilation is to ventilate without intubating. The physiologic effects of negative pressure ventilation versus NPV versus PPV. The cardiovascular effects of NPV are superior as opposed to PPV. The indications for negative pressure ventilation, mask intolerance, the need to increase pulmonary perfusion, among others. The benefits of NPV. There is no ventilation-induced lung injury, no positive pressure, no tube. The complications with the tank include tank shock. Contraindications include upper airway obstruction, which includes obstructive sleep apnea. And the enclosure types for negative pressure ventilators include the tank, the Kuros, and the wrap. We looked at ventilation operation. It is NPV is pressure controlled ventilation. We need to supplement the FiO2 with a mask or a nasal O2. With these ventilators, we have limited monitoring capabilities compared to our ICU positive pressure ventilators. Okay, let's turn to non-invasive positive pressure ventilation. The attributes of non-invasive positive pressure ventilation we can ventilate the patient using positive pressures without a tracheal tube. That's a big deal. Important attribute of positive pressure ventilation, there is always going to be some degree of leak on the mask. This affects the volume that is delivered. It also affects the ventilator being able triggered by the patient to inspiration and the ventilator cycling to expiration. The leak affects all of these. The modes that can be used with NPPV include CPAP, continuous positive airway pressure, and I've done this, used it hundreds of times. Then also we have bilevel positive airway pressure, or BiPAP, which also we've probably also done more times than you can believe. We can deliver pressure support, pressure control, volume control, proportional assist, and I didn't have it on the list here, NAVA, NAVA. We will talk about that. The physiologic effects of NPPV include decreased work of breathing. Obviously, that's the purpose, to assume the work of breathing. We get, with PPV, we get increased dynamic lung compliance. It will increase the tidal volume. It will increase the inspiratory capacity, CPAP, and COPD patients. Other effects include, obviously, improved blood gases, oxygenation is increased by an expiratory pressure because of increasing the FRC. Hypercapnia is decreased with the inspiratory pressure. Cardiac output for patients who are normal and patients who have COPD, the cardiac output can be decreased by PPV. However, some patients with congestive heart failure may experience increased cardiac output. The benefits of NPPV: prevention of tube complications, reduction in sedation requirements, prevention of a tracheotomy, and also PPV has been shown to reduce ICU length of stay. Complications of NPPV. Sometimes we may choose to use NPPV when the patient really is not capable of using the NPPV, and therefore we will delay intubation for that patient. And that's a bad idea. We delay the intubation, the patient goes sour, and then we have to do an emergent intubation. Other complications include patient intolerance. Patients just don't like it, and they can become very anxious. Can also develop facial ulcers, ear and sinus pain from the pressure. Also, we can't, if it's used inappropriately, this can actually increase the patient's work of breathing due to patient ventilator dysynchrony. This is due to inappropriate device, using inappropriate device, or inappropriate control settings. Another, this is on us. If the patient's work of breathing is increased, this is on us to correct it. Complications include, as with even with the tube, with invasive ventilation, patients can develop a pneumothorax. We also do, if with high pressures are used, we can inflate not only the lungs, but the stomach. Especially with a mask, a patient can aspirate. Patient, if we're not using adequate humidification, we can develop mucus plugging. Also, we can develop hemodynamic compromise. Contraindications to NPPV. If the patient is unable to fit or tolerate the interface that is chosen. Another contraindication, if the patient has facial trauma or facial surgery. Obviously, we do not apply a face mask to a patient who is vomiting or a patient who has an acute abdominal process, because if they do, there is the risk for vomiting as well as aspiration. Other contraindications include a patient who is apneic. Although, if we have that, this depends on the ventilator, because some ventilators we can control the patient with the ventilator settings. Contraindications include cardiovascular instability, excessive or viscous. Oh, this is a misspelling there. I'm sorry about that. There should be another U in viscous. Recent gastroesophageal esophageal surgery, and severely impaired mental status. Indications, and there are indications or it wouldn't be used. Obviously, one of them is COPD, acute cardiogenic pulmonary edema, blunt thoracic trauma, that is blunt thoracic trauma, post-operative respiratory failure, weaning from invasive ventilation. And we'll get to each of these as we go along. Others include, there are miscellaneous conditions that may indicate NPPV, neuromuscular conditions. It can be used in neuromuscular conditions. There is a separate lesson on neuromuscular conditions, and I encourage you to take a look at that, whether you pay for it or not. And also, it can be useful in obstructive sleep apnea, and there is also a separate lesson on obstructive sleep apnea. There we go. Questionable indications. In patients with ARDS or acute lung injury, NPPV may cause harm by delaying intubation. Then the patient has to be intubated emergently, which is a bad idea. Pneumonia. NPPV has no evidence of benefit. And however, now I need to change this in asthma. There also is no evidence of benefit. Okay, to continue, NPPV and COPD exacerbations. NPPV is a first-line treatment for COPD exacerbations. There is strong evidence for its efficacy in hypercapnic respiratory failure. The effects that have been shown to decrease the work of breathing, reversal of ventilatory muscle fatigue, decrease in the arterial PCO2, decreased risk for intubation of these patients, and decreased mortality. This is important. Patients with severe COPD, once they're intubated, as many of us have experienced, they never come off the ventilator. So this could save them a lot of grief, and the family as well. Stable COPD patients. Okay, importantly, many COPD patients also have sleep apnea. There is an overlap between the COPD and the sleep apnea with a greater risk for hypercapnic failure. With these patients, the NPPV decreases air trapping, therefore decreases the total lung capacity. It increases the patient's response to CO2. It also stabilizes the heart rhythm by reducing vagal activity. For stable COPD, NPPV can be used in the home, and it has been shown. I'm talking about studies, studies that support this. At home, there is a longer survival for those who adhere to the treatment, and adherence is a big deal. It also is very difficult to achieve. In rehab, for pulmonary rehab, it may increase the exercise tolerance. There was one study where the patients wore a backpack. In that study, it did not help. There is a therapy ceiling for end-stage COPD. That would be it. In other words, This is as far as we go for these patients, no more, no intubation. Now, for acute cardiac pulmonary edema, of course, we have a lot of, everybody sees a lot of patients who are non-compliant. Okay, for pulmonary edema, and this has been my favorite for pulmonary edema in the emergency department for years. There is strong evidence that for pulmonary edema, cardiogenic pulmonary edema, that positive NPPV is first-line treatment. The effects and now, interestingly, this studies found that generally that CPAP and BiPAP have equal effects. In other words, CPAP is enough for many patients. We get increased FRC, increased lung compliance, decreased work of breathing, and for these patients, decreased dyspnea and respiratory rate. Again, in these patients, they come in severe distress. It can be very difficult to get them to cooperate. That is the problem. The effects, again, CPAP and BiPAP work the same. BiPAP, NPB, may not be more effective than CPAP. This is a study. This is a statistical analysis. Going on, NPPV for blunt thoracic trauma, i.e., a flailed chest. Both CPAP and BiPAP were studied, and there's fair evidence for effectiveness of these for NPV. However, these were observed case studies which do not produce strong evidence. One small RCT was stopped because the NPPV was shown to be effective. Therefore, the study, the patients could not be denied NPPV. No, and this is ethics in research. During a study, if we find that the treatment is working, we can't deny it from the control group. We've got to give it to everyone. Okay, the patients who were excluded from this study were patients who required emergency intubations. Good for you, Dan. Okay, emergency intubations, the patients who had injuries to the head, face, or neck, and the effects were shown decreased rate of pneumonia, and also, most importantly, decreased mortality. The flailed chest has been a difficult thing to treat. CPAP and BiPAP were studied for post-op respiratory failure. Post-op respiratory failure. And post-op upper abdominal and thoracic surgical studies were studied. Thoracic surgical patients were studied. The effects of NPPV for post-op failure, decreased intubation and re-intubation rate, decreased pneumonia and sepsis, decreased mortality, and decreased length of hospitalization. In this also, the length of stay is a big deal. Money, I mean, it's not just money, but it's good for the patient, but better for everyone. CPAP, again, CPAP and BiPAP may be equally effective in these instances. Okay, sticky with here. NPPV and ventilator weaning. The rationales: to shorten the time for intubation. The tube causes morbidity. Shorten the intubation time will allow us to decrease sedation, decrease infections, decrease ICU and hospital length of stay. Again, all of these big deals. The rationale is to prevent re-intubation as well as preventing a tracheotomy. The supportive evidence is moderate to support NPV and ventilator weaning is moderate when it is applied to selected patients. Selected patients. It isn't good for everybody. They got to be selected. Patients who meet the criteria to initiate a spontaneous breathing trial. Those who meet the criteria for extubation, that means they do not have excessive secretions, they can generate an effective cough, have an acceptable mental status, and importantly, they are not a difficult intubation. If the patient is difficult to intubate, we may not want to take a chance on extubating until we are sure that they can be they will remain extubated. For weaning, the evidence is moderate. That also is moderate for patients who have no impediments for the interface. They can tolerate it. The patient must be able to tolerate short-term spontaneous breathing. That is to enable us to adjust the mask, etc. For post-extubation failure, the evidence does not support NPPV in treating post-extubation respiratory failure. Doesn't treat it. Doesn't work for treating post-extubation failure. However, the evidence supports that it may be effective in preventing post-extubation respiratory failure when the high-risk patients are identified in advance. NPPV is not recommended as a routine intervention for post-extubation situation. That's the bottom line. Miscellaneous indications. NPPV can be administered during bronchoscopy to offset the increased work of breathing and hypoxemia. It may be indicated for severe bronchiolitis and in cystic fibrosis patients who are adults with hypercapnic exacerbations. Same as for COPD here. Also, it can be used for patients who are immunocompromised because NPPV will prevent ventilator-associated pneumonia because of the tracheal tube. It may also be useful for patients with pandemic respiratory infections such as SARS and COVID to prevent infection of caregivers during intubations. And it is during intubations that there is high risk for spreading the condition. Let's summarize and review for this section. The physiologic effects of NPV may increase cardiac output in CHF. However, for most other patients, it decreases the cardiac output. The benefits of NPPV: prevent intubation. That's a big one. Complications. One among these is delayed intubation. The patient needs intubated. It needs to be done without screwing around with BiPAP. Contraindications for NPPV include, of course, intolerance of the interface, the mask. Indications: cautious application to hypoxemic failure. Continuing with the lesson, non-invasive ventilation, interfaces, humidification. Okay, the issues with the interfaces include patient comfort, allowance for patient to move around, the weight of the interface, which also goes back to comfort. Importantly, the whether the interface is allergenic or not. For instance, many people are allergic to latex, so latex must be avoided. Biggest issue probably is pressure that is applied to the tissues. And this pressure to the tissues, when you apply pressure to a tissue, it inhibits blood flow, so this can lead to skin ulceration. Other issues include the internal volume of the interface. This internal volume, if it's particularly, I'm speaking of a mask, rebreathe dead space ventilation, rebreathe volume. The patient it exhales into the mask, then they rebreathe some of that air. Another issue can be that the volume of the mask will be compressed. So we get compression and decompression volume due to the mask, the volume in the mask. Also with issue leaks, that with a mask seal, 2 centimeters is about right. That is negligible leak. It's important with the interfaces, so we have multiple sizes available. One size does not fit all. Other issues with the interface include the methods. I'm sorry, I stopped so I can read these chats. The headgear for securing the interface. The headgear there must be comfort there. There should be stable. It should be easy to use, the headgear. For home use, it should be washable. For hospital use, the headgear must be disposable. Here are the types of interface we have for NPPV. First, mouthpiece. And the mouthpiece is good for intermittent use, a short term. Then there is the nasal mask, nasal pillows, the oronasal mask, the total face mask, and finally, the helmet. The mouthpiece interface can only be used in the daytime for patients with neuromuscular disease, patients with COPD, and patients with cystic fibrosis. Nasal interfaces. The indications for nasal interface, it is the primary interface for obstructive sleep apnea. It is also a good starting interface in mild acute respiratory failure with some limitations. It also can be used for postoperative atelectasis. It actually can treat post-op atelectasis, not prevent it, but treat it. There is a lesson on this website about lung clearance. That is where you find it's the research on atelectasis. The nasal interface has several advantages. First, it enables the patient can speak, they can eat, they can cough. With a nasal interface, there is less risk for aspiration and less risk for gastric distension. There is a pop-off using nasal CPAP. The mouth is a pop-off. Also, with a nasal interface, we have less opportunity for claustrophobia to occur. And that is a problem with many patients, claustrophobia. The limitations of the nasal. We can't really monitor the exhale tidal volume. Nasal resistance limits the effectiveness of the ventilation. If the patient breathes through their mouth, that limits the effectiveness, and patients with acute respiratory failure tend to breathe through the mouth, so it may just not work. With a nasal interface, less pressure can be administered. And here are some examples of the nasal interface. These are nasal masks. And I put different brands up here so we wouldn't be accused of advertising for any one or bias. No bias with regard to these equipment. And then there are the pillows. And the pillows are more comfortable than the masks. Many patients prefer these. So that finishes up with the nasal interface. The full face mask is the most commonly used for bilevel NPPV. The full face mask has advantages that there is less leakage than with the nasal. We can therefore have more stable pressures to deliver to the lungs. And however, the full face mask requires less patient cooperation than does the nasal interface. The limitations with a full face mask include claustrophobia and the possibility of aspiration. And here are some examples of the full face mask. Again, different brands. Then there is the total face mask. We have the full face mask, then this is the total face mask. This is the most effective interface for acute respiratory failure. With the total face mask, we get minimal leaks. So the total face mask accommodates the greatest ventilation pressure. It appears to have produced less discomfort and less pressure injury because there is a larger area of contact between the interface and the skin. Total face mask does not increase dead space. It may, however, increase claustrophobia. And here are some pictures of total face masks. And then the advantage, then there is the helmet. And I've never used a helmet. If anybody of you have, I'd like to hear from you. Research compared non-invasive oxygen delivery methods using a helmet versus a face mask for patients with acute ARDS. The trial was stopped early because the helmets proved more effective than the face mask for treating this condition. Okay, it's the same with it I mentioned earlier. If a clinical trial shows that the intervention is working better than the control, they have no choice but to give the intervention to everyone. The advantage of the helmet. This is the very best interface for COVID infection. The helmet overcomes mask fit problems. It is more comfortable than the total face mask or the total face mask. There is no facial pressure injury. There is less need for patient cooperation. The helmet does allow speaking and coughing. And hopefully we'll see a video on helmet NPPV. I mean, hopefully it's good. I mean, there are no glitches in it.
The helmet interface for delivery of non-invasive ventilation is a transparent hood that covers the entire head of the patient. A soft rubber collar seals the hood at the neck. First, measure the neck size of the patient. Using the collar size guide, determine where to cut the rubber collar to ensure a tight yet comfortable seal at the neck. Attach the rubber collar to the plastic inner ring of the helmet. Now attach the inner ring to the helmet's transparent hood and ensure a tight seal. Attach the ventilator's inspiratory and expiratory tubing to the port sites on the helmet. Set the ventilator to pressure support mode. To improve patient ventilator synchrony, adjust the rise time to 50 milliseconds and change the end flow to 50%. Stretch the rubber collar of the helmet and place over the patient's head. Once the helmet is fully inflated, attach felt arm straps to the front and back of the helmet. This secures the helmet's position on the patient's head. The helmet pressurizes in seconds. PEEP is increased to achieve adequate lung recruitment and oxygen saturation. Notice that at this level of PEEP, there is no detectable leak in the ventilator circuit. FiO2 is also titrated to a non-toxic level to achieve oxygen saturations above 90%.
Jolly good. Obviously, there are disadvantages. In infants, the helmet may decrease cerebral blood flow, which is a big problem. The helmet impedes patient triggering due to decompression volume within the helmet. With the helmet, there is no capability for volume monitoring. And finally, humidification may fog the helmet. And I agree with you, Keith. It would be a good idea to have these during COVID. And here are some pictures of helmets. And there is one more. There is a designer helmet. There it is. This is a designer CPAP helmet. Luke. All right, let's turn to the ventilators themselves. The ventilator circuits can be single-limbed or double-limbed. The single-limbed circuit was the original BiPAP circuit. and it leaves it's not the best. Okay, the single lump circuit does incorporate a variable flow leak port. There must be a flow leak port. Requires EPAP, expiratory pressure greater than 4 centimeters of water to minimize rebreathing. The double limb circuit is used in ICU ventilators and our more recent, our newer bi-level ventilators. And I started with one with, we'll get to where I started with, but it was a very difficult equipment to work. Double limb circuits. They're in ICU ventilators and recent BiPAP ventilators. They do double limb circuit eliminates rebreathing altogether. The circuit and interface must be used for the specified ventilators. It is not one size fits all, one brand fits all. Humidification for BiPAP. No humidification may be okay for short-term ventilation. However, humidification of the high flows we're using, humidification, the ability of the mucosa to humidify can be overwhelmed by BiPAP. Desiccated mucosa releases inflammatory mediator, and there can be possible mucus plugging. Absence of humidification can impede adherence to the therapy. In other words, patients like it, feels better to them when there is some humidification. So what do we use? HME can be used, but these will increase the resistance to flow. They also can increase dead space ventilation, dead space breathing, rebreathing, leading to hypercapnia, increased minute ventilation, and also increased work of breathing. So this is not the ideal. Heated humidification. If we're using heated humidification, there is no effect on dead space, no effect on resistance. And for some patients, just ambient temperature, passive humidification, whatever humidifier you're using that uses the, of course, water, doesn't necessarily need to be heated. Ambient temperature increases the comfort. Okay, summarize review. We talked about in this section, the issues with the interfaces include comfort, pressure injury, and leaks. And the specific interfaces we looked at, the mouthpiece, nasal mask, the pillow, oral nasal mask, total face mask, the helmet, and I honestly, I did this a while ago. I've not been able to find if the helmet is approved by the FDA or not. I'll have to check on that. I'm sorry. That may be why you didn't have it through COVID. Okay, we also looked at the circuits used in non-invasive PPV, single versus double-limbed, and humidification. HMEs produce increased dead space, whereas passive or ambient temperature humidification will work for some patients. However, humidification for long-term NPPV is absolutely necessary, heated humidification. Okay, let's look at some of the devices that are used in NPPV as well as the controls. Our ventilators. First, there are institutional bi-level ventilators, institutional BiPAP machines. What we want in these, the desirable features, we do want a blender. We do want leak compensation. We do want trigger compensation, a backup rate. We need a rise time adjustment, a graphic display, alarms, and a battery power supply. These are desirable. They aren't necessary. They're desirable. Okay, some of the institutional BiPAP machines include the BiPAP ST, and I've used these many times, and they have no blender. The Respironics Focus, which also has no blenders. Those with blenders include the Vision and the V60. These are all the newer BiPAP machines. The Vision is used for acute care bi-level ventilation. It does have a blender, so the FiO2 is adjustable. It has what Respironics calls auto track triggering, so it's easier for the patient to trigger it. Rise time is adjustable. It does have a graphic display. It does have alarms. The only thing it doesn't have is a battery backup. The V60 is another acute care BiPAP machine. It has average volume assured pressure support, average volume assured pressure support. Excellent. Auto adaptive leak compensation, inspiratory triggering, expiratory cycling, which is excellent, an adjustable ramp time, a built-in blender, and the V60 does have a battery backup up to 6 hours. Okay, then other than those were the BiPAP machines. Now we can also do non-invasive ventilation with our ICU ventilators. Now, the ICU ventilators, if they have a non-invasive mode, they will provide leak compensation. See, the problem is that if the ventilator does not have an NIV mode, there will be no leak compensation. And if there's no leak compensation, that will impede patient triggering. Patient cannot trigger the machine. It will also impede cycling to expiration when the pressure support mode is being used. It can be used without the leak compensation. These ventilators can be used, but it's not a good idea. It could lead to problems such as injury to the patient and, of course, leading to litigation. Yeah, and I have a problem with dry eye there too. Okay, here are the ICU ventilators with non-invasive modes. The McKay Servo I, and I gotta tell you right here, since the first servo came out, and it was Siemens servo at that then, I have been a big fan of servo ventilators. McKay Servo I, the Draeger Avita XL, the Newport. I've used Newports a lot, and I like the Newport ventilators. And this is personal. I have no financial interest in any of these. I'm talking about from experience. The Newport E360 and the H250 transport ventilator have non-invasive modes. The Viasys Vila and Avia, the Hamilton Raphael, and C2. Interesting. Okay. The Hamilton, Raphael, and C2, the GE, Engstrom, Care Station, and the Puritan Bennett 840. Those are with non-invasive modes. Then there is the ventilator intervention technology accessible locally, VITAL. The VITAL ventilator was developed by NASA for pandemics, such as COVID. I don't know if any of you have had the opportunity to use these. I have not. But this is what was supposed to be ready from the government for use. Okay. They're tested in the Jet Propulsion Laboratory and received FDA emergency authorization in April of 2020. The VITAL uses some parts from available ventilators, and there are 8 U.S. manufacturers licensed to produce the VITALs. The VITAL has assist control. It has volume targeting, PEEP adjustable between 5 to 35 centimeters, frequency from 4 to 40 breaths per minute, the tidal volume 150 to 800 mLs. Obviously, that frequency with some youngsters, it would not work. And this is a photo of the VITAL ventilator. Okay, using ICU ventilators with, if they have the NIV mode, they must have the NIV mode, the ICU, the advantages. They have graphics to show the triggering, the cycling to expiration for us to determine intrinsic PEEP and also to judge work of breathing. And here are some ventilator graphics. This is a display of pressure versus volume. And we see that with the work of breathing is contained within that curve. On the left, the work of breathing is decreased compared to the right. The work of breathing is greater. So we look at this graphic and see what we can do to decrease the spontaneous work of breathing. Okay, also with the ICU ventilators, we have exhaled volume monitoring, expiratory cycle adjustment, rise time adjustment, and the capability to just switch over to invasive ventilator. In other words, instead of having to change from a BiPAP machine to a ventilator, we already have the ventilator there. So it is incredibly useful, time-saving. The disadvantage of the ICU ventilators, these things cost an arm and a leg. So the hospital can only afford so many of them. With hospitals running out of ventilators, this can be a problem. The modes that can be applied to non-invasive ventilation include volume control. Volume control has an identical success rate compared to pressure control. With volume control, we deliver stable volumes in the face of changing lung mechanics. Higher peak airway pressures that caused flatulence in 2 patients, and the flatulence sounded like a mask leak. Okay. This mode is common in home non-invasive ventilation, at least in Europe. Sorry, that flatulence thing. I'm sorry. Farts are funny. I don't care what you say. Then another mode applied to NIV include pressure control ventilation, PCV. With PCV, we get stable volume delivery in face of leaks. Importantly, with pressure control ventilation, I do love pressure control ventilation and pressure support. The flow is variable with patient demands. And though the patients want more gas, they get it. Pressure control ventilation may be more effective than pressure support for COPD exacerbation. And again, it may be. Pressure support, of course, has been the most common mode for non-invasive ventilation from the get-go. However, some ventilators do not include a backup rate, so the apnea adjustment is important, must be there. With pressure support, appropriate expiratory cycle adjustment is important. It is vital because if the damn thing won't cycle into expiration, it causes the patient problems. Also, an appropriate rise time adjustment is also important, and we must observe the inspiratory time and ITE ratio that will require us to adjust the inspiratory time limit. Then there is proportional assist ventilation. PAV delivers flow proportional to the patient's inspiratory effort, and it terminates flow in response to cessation of inspiratory effort. And I've never used PAV. Clinical trials conclude that PAV is better tolerated than PSV, but in this trial, the pressure support ventilation was delivered with a Puritan Bennett 7200 AE, and I need to point out that the Puritan Bennett ventilators have not historically have not been as patient friendly as other ventilators. Respironics Vision PAV is not available in the US. Puritan Bennett 840. The company does not support the use of PAV with non-invasive ventilation. Then there is pressure support with volume guarantee. No non-invasive ventilation with trials have been located. The problem with VSV is the patient distress and hypercapnia causes the ventilator to decrease support, which is exactly the opposite of what we want. Because if the patient is getting tired, then the machine will not detect that, will not respond to the patient wearing out. Then there is neurally adjusted ventilatory assist Mackay NAVA. This is on the Mackay ventilator. It's been around for a while. NAVA delivers flow in response to diaphragmatic electrical activity. So NAVA eliminates leaks totally as a triggering and cycling factor. We need human trials on NAVA with non-invasive ventilation. However, it does work on rabbits. And don't ask me what happened to the rabbits. I don't know. I do care, but I don't know. I love animals. I'm a dog lover, especially. Okay, so yeah, Keith Rabbit Stew. What was that? The movie where where the rabbits were involved. The woman. I'll think of it. It doesn't matter. Okay, settings for ventilation. Settings for the ventilator. PEEP should be between 3 and 10. Pressure support or pressure support ventilation, IPAP. Exhaled tidal volume should be in the neighborhood of 5 mLs per kg ideal body weight. Reasonable starting pressures, and this is the way it's been for. It's still that way, but it was years ago. Reasonable starting pressures for BiPAP, PEEP of 5, and pressure support of 10. The FO, and we select the FI2 for the desired saturation. Expiratory flow cycling adjustment must be done for patient comfort. We use the ventilator graphics to adjust the expiratory flow cycling, and we also observe the inspiratory time, observe and adjust inspiratory time and I to E ratio. All of these, we do these to adjust, to eliminate intrinsic PEEP. Okay, and here are some graphics of flow cycling with pressure support ventilation. We see the top curve shows that peak in the curve shows that there is patient expiratory effort. We don't want the patient to produce any effort for expiration. It should happen automatically, physiologically. The second curve shows late termination of the expiratory flow. See the flow actually goes to the negative side, and that is bad if it terminates late. Do you go back one, Keith? I couldn't see that. The chat feature covers part of this screen, so I can't see it. Okay, the lowest curve shows the patient is unable to trigger the ventilator. See that negative inflection on the flow, the negative pressure. Okay, now we go to next. Then there is rise time adjustment. Rise time adjustment is done to produce increased patient comfort, and we also use ventilator graphics to determine rise time. And here is an example of the graphics to show the use of the rise time. And this is the pressure versus flow, pressure flow curve. And we see on the top one, we have a linear or bowed upward rise in pressure after trigger on the pressure wave. The patient shows the patient is not getting adequate flow. We see a slow rise in the pressure and the concave shape of the pressure wave. Again, inadequate flow. The green line at the top shows that there is an adequate flow to the patient, so the rise time is adjusted appropriately. Okay, that's the end of the new information. Looks like I'm a little bit early, but I'm sorry. To summarize and review, we looked at the types of ventilators that are used for non-invasive positive pressure ventilation. We looked at the specific bi-level and ICU ventilators and the advantages and disadvantages of the ICU ventilators used for non-invasive ventilation. The disadvantage of the ICU ventilator is primarily the cost of the ventilator. We looked at the NPPV modes and also the ventilation settings, including rise time and so on and so forth. Let's look at some clinical issues with non-invasive NPPV. Okay, the favorable indicators that NIV will work. First, if there is a favorable response in the first 2 hours of NPPV. If the patient has an Apache score of 2 of less than 20, Apache scores are used for it's a critical illness score. The higher the Apache score, the worse off the patient is. So we look at the Apache score. The pH must be greater than 7.30. The patient should have a Glasgow Coma score of greater than 15. That is a measure of neurologic function. Okay, other clinical indicators of favorable response, absence of pneumonia or ARDS, minimal interface air leaks, and we must have patient ventilator synchrony. Another issue, delivering aerosols for patients on non-invasive ventilation. And I've got to tell you this right now, I am an enemy of nebulizers, of most, let's say, pneumatic nebulizers. Okay, to deliver aerosols, we must remove interface and administer if it is safe and feasible. If we can do it, if it's safe, we can administer an MDI. Aerosol medications are effective with non-invasive ventilation with all types of devices. Aerosols are even effectively delivered by the nasal interface, believe it or not. However, an increased dosage of the medication may be necessary because of leaks and nasal deposition. So the delivery devices, if we are using a pneumatic nebulizer, and again, I'm an enemy of those, despite the fact that I've delivered thousands of treatment with pneumatic nebulizers, it should be placed proximal to the patient. It should be placed between the patient and the leak valve. However, the better type of nebulizer to be used is a vibrating mesh nebulizer, such as the AeroNeb Pro, because this type of nebulizer does not add flow to the circuit. It does not add oxygen to the circuit. This is a goodie. Meter dose inhalers and spacers can be used with non-invasive ventilation. We must time our administration to coordinate with inspiration. If we press the button while the patient is expiring, obviously that's not going to work. Aerosol delivery with a total face mask. It will allow medications to enter the eyes. And this is a problem if we're administering Atrovent, because Atrovent has been known to cause a problem with the eyes. More research is needed to generate specific recommendations. But regardless of the device, it's a good idea to place the, okay. And this is kind of a joke. This is a tongue-in-cheek joke. Regardless of the device we're using, it's a good idea to place the aerosol generator between the HME and the patient. And I say that as a joke because I indeed one time caught myself putting a nebulizer in line before the HME, and I caught myself, but the HME is obviously going to filter out the medication. Heliox therapy. A big study of studies on the routine use of heliox for asthma and COPD do not support it. It is expensive and obviously it doesn't work. Heliox will decrease intrinsic PEEP and work of breathing in ventilated patients with COPD exacerbations. Problems. We can't use heliox in patients who are hypoxemic. Heliox will cause errors in tidal volume and FiO2 measurement and delivery. The only FDA-approved ventilator for heliox is the Viasis Avia. Heliox is expensive, and it does cause vocal distortion. Of course, many of you have probably even tried this. Okay, the sites for administration of NPV factors include how acutely ill is the patient, also the expertise of the personnel. Is the patient, do we just have an aide available to do this, and is the aide properly trained? Also, the availability of physical resources and the monitoring capabilities. We need skilled personnel, and we also need electronic monitoring. Okay, sites. Pre-hospital NIV is administered by EMS. For some conditions, the sooner the better. For NPPV, especially for pulmonary edema and COPD, it can avoid emergency intubations. So again, the sooner the better. And EMS, the EMS people I've known, have worked with, we're very familiar with it. In the emergency room, we administer NPV, we administer early, and we have advanced resources in the emergency room because this includes us, respiratory therapists, or RCPs, whatever you choose. In intensive care, this is the best place for the sickest patients. We have intensive monitoring available. We have extensive physical resources, and we also have personnel resources, which are the best, the respiratory therapists and the critical care nurses. Okay, NPPV is also administered in step-down units or intermediate care. There usually is telemetric monitoring. We have personnel resources that vary. We may have respiratory therapists. They won't be in intermediate care, may not be there all the time, but they're available. And we need to also keep in mind that patient-nurse ratio in the intermediate care is not equal to that of the ICU, and we must have stable patients, sick but stable. In the general ward, there may be telemetry. There are many more patients per nurse, and the nurses may be unfamiliar with ventilation. Respiratory therapy coverage varies in the general wards, And here is where we would use an intermittent NPPV. Intermittent NPPV as for sleep apnea, stable COPD, and stable neuromuscular disease. In long-term care facilities, we're involved with chronic care, and these may include patients with COPD and also patients who failed to wean from ventilation. In these long-term care facilities, monitoring varies by the units themselves. The individual units usually have skilled respiratory therapy staff, and again, that's usually. Home, of course, NPV is used at home all the time. Can be used for chronic conditions, for end-of-life care also. It does require education of the patient also, and the caregivers, and this often is the family. Which leads us to the issue of NPPV and end-of-life care. First, we have patient choices. Patient may have an order, do not intubate, or they may have comfort measures only. Informed consent of the patient or the family is needed because non-invasive ventilation is life support. And that, I got to tell you, I worked in a place years ago, and there was a physician for which I had absolutely no respect. And we had a patient, an elderly patient, who was a DNR, and she was, the physician at night decided he wanted, in the evening, he wanted blood gases done on this patient. Again, she was a DNR, blood gases, and then when the blood gases were not good, he wanted BiPAP. And the patient, and I pointed out to the family, this is very uncomfortable, but the family went along with it because the doctor ordered it. So, okay, common conditions for NIV at end of life include COPD, cancer, neuromuscular diseases, and also chronic heart failure. The goals of NIV for terminal patients: delay death. That sounds awful, but some patients want their death simply delayed for good reasons. They may want to die at home. They may want to stay alive long enough to settle personal issues. They may want to delay death to see a person to say goodbye. NIV may be used for these patients to provide comfort, but I ask, comfort for whom? Is it comfort for the family, for the doctor, or for the patient? Obviously, it should be for the patient. It may decrease dyspnea. However, it is not a comfort measure when a patient is resisting the treatment. If they don't want it, it is not giving them comfort. Okay, there is ethical controversy whether NIV ought to be used at end of life. The decision should rest with the patient. And again, that is my opinion, and I hope that many of you agree with it. If you don't, the hell with you. Okay, summary review. The indicators for successful NPPV we looked at. Aerosol delivered does work with non-invasive ventilation. So if the medication is ordered, it will deliver it. Heliox may decrease work of breathing for COPD. Heliox is very expensive and it does cause problems. We looked at the sites for non-invasive ventilation, and these include everything from the ICU to the home. And also we finished up with talk about non-invasive ventilation for end-of-life care. Okay, folks, that is the end of the information for this lesson. And I thank you very much for being with us today. And I love you all. Always remember, never forget, life is life, fun is fun, but it gets damn quiet when your goldfish die.